I would like to first thank Jane and the organizers for the opportunity to attend this workshop and to give a presentation on the guideline studies for chronic toxicity and carcinogenicity. When I was preparing my talk, my original plan was to give an overview of the current stand of the guidelines, but after taking a look at the databases, it quickly became clear to me that this would not be relevant for our discussions today. And that is because of the two databases used to derive the thresholds for toxicological concern are based on the carcinogen potency database and also on the database used in the analysis by Monroe. And as you can see, most of the studies from the carcinogen database come from two major sources, and one of them is the bioassay program from the National Cancer Institute, and this includes all studies between 1976 up to July 1980. And the second portion of studies come from bioassays published in the literature between 1948 and 1981. And in the Monroe database consists of studies that were performed between 1921 and 1993. So based on this fact, then I decided it might be more appropriate to give a brief overview of the history of the development of the guidelines, because this would then allow us to place the data from what we are talking about into better historical context. So, and as Jane mentioned previously, the first guidance that the FDA has provided to the industry occurred in 1949 for assessing toxic chemicals in food. And at this time, all of the testing were focused on intentional administration of compounds, for example, what's going into the food and for pharmaceuticals. And at this time, the FDA recommended the use of 3 doses. The first one being a maximally tolerated dose, an intermediate dose, and then one that is 100 times the amount proposed to be used in the food. And then approximately about 10 years later, the World Health Organization published their own guidelines, and they recommended the use of only 2 dose groups plus a control group. So you can see here that the 1950s marked the first attempts at standardized testing with an emphasis on only qualitative hazard identification and with a focus on food additives and pharmaceuticals. So it wasn't until the 1960s, the 1970s, that interest was generated in testing chemicals that we're exposed to from the environment or in the workplace. And so up to this time, there had been absolutely no routine testing on environmental chemicals. And also at this time, there was a push to get a degree of standardization of the bioassay protocols, because up to this time, the studies had not been well performed, and this was based on an investigation from 2 scientists, the Weisbergers from the National Cancer Institute, who looked over all of the bioassays conducted up to that time point and found them deficient in details regarding, for example, dose, length of treatment, and found some that did not use control groups or did not have correct controls. So based on this information, part of the impetus then was for the National Cancer Institute then was to develop guidelines for a carcinogen bioassay. And this is the bioassay that is in use for most of the studies that the carcinogenicity database is based on. And then in the 1970s, 1980s, marks the first time when there was an organized shift in thinking, so to speak, in the terms of risk assessment of chemicals, in the sense that there was a shift now toward thinking about quantitative risk assessment. And this can be seen by the fact that the FDA and the EPA both published guidelines not for studies that needed to be performed, but for people who were doing risk assessment. And so I'd like to point out, so this is the stand of the standardized testing at the point when the carcinogenicity database was complete. And this represents the stand of the standardized protocols for about half of the studies that have been included in the database by the analysis from Monroe. And so after 1981, the Organization for Economic Cooperation and Development, the US FDA, and the US Environmental Protection Agency all adopted guidelines which are pretty similar in terms of their recommendations. And all of these guidelines have been updated since. So in purposes for my discussion today, I'm going to focus on and give you just a basic structure of the guidelines used by the National Cancer Institute in their bioassay program. And then I will briefly discuss the OHCA guidelines for chronic toxicity, which is based on the 1981 version, which I think is then more relevant for at least half of the studies that we're talking about today. So the objective of the bioassay studies from the National Cancer Institute are to determine the carcinogenicity of the test agent in both sexes of 2 species and is designed to cover the greater part of the animal's lifespan. The guidelines called for treatment to begin approximately as close as possible after weaning, and the treatment was supposed to last for approximately 24 months so that a maximum response could be achieved. The recommendations in terms of dose level were only the use of only 2 doses. And the guidelines stipulated that a maximum tolerated dose had to be used, and then the second dose would only be a fraction thereof that, which was arbitrarily chosen at 25% or 50%. The main endpoints for the carcinogen bioassay is the development of tumors. So the point of the studies was to compare the incidence of tumors in the control animals with the incidence of tumors in the treated animals. So the basic endpoint was palpation of the animals at least once a week for identification of large tumors, and then histopathological examination of all organs from the control and treated animals. So this is a very quantitative, this assessment is based on discrete variables. We're looking for a yes and no answer. Does this test substance have a potential to cause cancer? And so now I'll present the guidelines from the OHCD, which were adopted in 1981. The objective for these guidelines of a substance Can you hear me? Okay, very loud. That's okay. Okay. So the objectives of the chronic toxicity studies guidelines state the purpose is to characterize the profile of a substance in a mammalian species following prolonged and repeated exposure. And then as a secondary addition to this, it said that the data should be able to generate data on identifying the majority of chronic effects and to determine the dose-response relationships. So again, it was recommended to start exposure after weaning. The test was supposed to be conducted, or the animals were supposed to be exposed for a duration of 12 months. And again, the guidelines suggest the use of a maximally tolerated dose, and this has been a characteristic of all the bioassays conducted up to this time point. But in this case, we now have the addition of a third dose, and in this case, the third dose should produce provide a test group that does not show any signs of toxicity. So here we're seeing the first idea of perhaps looking for identification of thresholds so that we are able then to perform a more quantitative analysis for risk assessment. So you have to remember these guidelines were first developed in 1981. The observations in a chronic toxicity test are extremely general. They include a daily clinical exam, look for changes in body weight or food intake, which might give you an indication overall toxicity. Hematological parameters were also evaluated, including differential blood counts. Urinalysis and clinical chemistry were performed, and that is to see if there perhaps are any effects on metabolism or on the kidneys or on the liver. And then at the end of the study, necropsy was performed, and it was recommended then to perform histopathological investigation of approximately 40 organs. And at this point, the first recommendation was that you only analyze the highest dose and the control group, or any animals which may have been prematurely died during the experiment. So any changes in these kinds of endpoints would only provide you with information about where more specialized tests might be done. The information coming from this type of study is not a very rich one. So I'd like to quickly summarize perhaps 2 points of consideration regarding the guideline studies and what kind of implications these might have when you're looking at the data from the studies that have been used for the data banks to derive the TTC values. So it's important to remember that the majority or pretty much all of the studies that were performed in these databases came from a time when there was an emphasis on qualitative risk assessment. And this can be clearly seen by the objectives, the stated objectives of the studies. And the stated objectives of the studies are also very intimately associated with the selection of doses of these studies. So at the time when the studies were performed for the data bank, there was an emphasis on experimental designs on hazard identification. And that is reflected by the use of a maximally tolerated dose and the use of only 1 or 2 additional dose levels. So this clearly shows, and the use for the maximum tolerated dose was that you didn't want to avoid seeing any uncommon effects in a group of a limited number of animals. And then followed by that, there were only 1 or 2 additional doses being evaluated. So here, clearly, there is no emphasis or no objective in characterizing a dose-response curve. And perhaps this change in thinking can be best illustrated by looking at the current guidelines for chronic toxicity testing. This list of objectives is from the guidelines adopted by the OECD in 2009. And here you can see that the objectives have been expanded considerably. The first 2 objectives are still are focusing on the qualitative assessment. What is the possible hazards from this chemical? But you can also see now the objectives of the test have been expanded much more because there's more interest now in doing a more quantitative risk assessment. And if you take a look at these objectives, the first thing that becomes clear is I cannot possibly design one study to serve all of these masters. There's absolutely no way, with the limit of using only 3 dose levels, can I answer all of these questions. But one of the good things about the guideline studies now is that they're giving more assistance and more flexibility in the selection of doses. Because for example, in the situation where if there is a chemical where we have more information regarding its possible hazards, we can shift the emphasis of the test into looking at data that will help us better with more quantitative risk assessment. And this can be done by not having to use this maximally tolerated dose. Because if you can imagine, if you are forced to use very high levels in a test system, you may end up with the problem that you oversaturate metabolism. And so your 2 doses could then result in the same internal dose. If you have 2 higher doses that both saturate metabolism, the same internal dose then could be arrived at, and then you would achieve the same response. So it is impossible then to characterize a dose-response curve and to make a robust estimation of possible threshold levels when this situation is occurring. So the flexibility then in the guidelines now state if there is enough information on hazard identification, because that still remains to be the main part of the study, but the investigators now have more flexibility in choosing a range of doses which surround areas where there expects to be changes in threshold level in terms of, for example, in mode of action or in metabolism. And the other good thing about this ability then to choose a different range of doses is that a range of doses which are more pertinent to the human exposure levels can then be administered to the animals. And then we can get better characterization of the dose response curves which are actually occurring in the areas of human exposure. So the second point I would like you to consider is the timing of exposure. All of the chronic bioassays recommend exposure as soon as possible after weaning. And this is a postnatal day 21 in the rat, and then up to no later than 6 to 8 weeks. And if you look at the inclusion of the published literature, or one of the criteria for the inclusion of the published literature in the carcinogenicity database, stipulated that exposure had to commence only before postnatal day 100. So in these studies that are represented in the data banks, in utero and early postnatal development and possibly puberty have not been routinely evaluated. And this has important consequences for both the chronic toxicity testing and for the carcinogenicity testing. Because the time period of development is a period that is believed to be of increased sensitivity to external exposures. And we know this from experimental teratology studies, which have shown us there are known periods of very high sensitivity for producing certain types of malformations. We also have information from epidemiological and animal studies regarding disorders of homeostatic systems, such as, for example, diabetes and hypertension. And these studies indicate that the predilection for these kinds of disorders can be affected by programming in early life. And finally, we also know from studies that organizational changes and permanent changes can be seen following steroidal exposure during development, whereas if you were to expose an adult organism, you could possibly then only result in activational or reversible changes. So it's very hard then to extrapolate the findings from these studies to protect all the subpopulations that we would like to protect. And secondly, in terms of carcinogenicity, it's extremely difficult to take data that have been collected from an adult and then apply it to the fetus or the neonate. And this is because quantitative and qualitative differences can occur between the two situations in terms of carcinogenicity. And this has to do with the fact of metabolization. For example, the fetal and neonatal metabolizing system is not very well developed. Well, in terms of carcinogenicity, this could be useful, or in terms of other types of toxicity as well. This could be either useful in the sense that certain compounds may not then become metabolized into their toxic compounds, and this would be more of a protective effect. But on the other hand, the neonatal and fetal systems also do not have a developed detoxification system. So it's very hard to predict how exposures during this time will then will either be result in carcinogenicity later on in life. And the maternal metabolism then also complicates the picture, just as the fetal metabolism does, because the maternal metabolism could also then have protective or inductive effects. And finally, the fetus and the neonate are more sensitive to carcinogenic insults due to the rapid rate of cell division which occurs during development. And this would then allow the persistence of mutations before repair can occur. So my last thoughts are, and to bring up for discussion, is how robust are the NOELs derived from data attained from experimental designs emphasizing hazard identification? And my second question is, how do we assess risk for developmental exposures when adequate data for this is lacking in the databases used to derive the TTC values? Thank you.